Right,
Go for it.
okay, I'm gonna give a little intro, Dr. Martinez, and then you're gonna take over, okay?
Okay.
All right,
Yes.
so welcome everybody to today's didactic training. We do this once a month. And today we have the pleasure of having Dr. Martinez present on working with persons with disabilities. Dr. Martinez is a professor at Pepperdine University and has now been there, he'll tell you how long, 30 some years. However, I have the pleasure and the luck, the fortune of knowing him since I was an undergrad at UC Riverside back in the early 80s. And so he was just a very young doctoral person who was teaching I think it was an advanced course.
Very inspiring. You don't remember the class.
Well, I know it's not, I was really lucky to have it because wasn't supposed to be taking the class, but I did. It was on
It was an internship.
yeah, it was on DSM. It was on the DSM was diagnosis and issues. So it got me kind of knowing what I was going to headed for becoming a clinical psychologist. Anyway, so I know him since then, and then I worked for him at El Centro de Amistad in Canoga Park and in Pacoima after I came out of my program, and was then Dr. Cardenas working with Dr. Martinez. So since then, we've had a relationship and been working together and collaborating on different things, and he's going to be giving us his expertise. And as well, we're going to be working with him is Benjamin Juarez, who used to work with us as a practicum student, and now he's a graduate student in a doctoral program in Utah. So he's still linked to Dr. Martinez and us through this. So there you go. Take it away, Dr. Martinez.
Okay. All right. Well, thanks for that introduction, Dr. Cardenas. And so as Dr. Cardenas is saying, we go back a long way. I remember when he was a lad, a young pup, just starting out. And so it's kind of interesting that our paths have crossed, and Benjamin is just one of my recent graduates. And so that is one of the things I'm most proud of, is the training I've done. I work at the Graduate School of Education and Psychology. And so I have trained about 900 therapists, I figure, in my professional career. I also very proudly created the Aliento program that I don't know if you're familiar with. Is a Spanish-speaking mental health treatment program, training program at the Irvine campus at Pepperdine. It's all Spanish-speaking MFT training. And it's a very successful program at this point. So my commitment is obviously to train Latino professionals and therapists, and that's kind of what I've done in most of my life. But I'm a trainer and a professional cross-cultural psychologist, I guess, in many ways, that I teach multicultural psychology. And so Dr. Cardenas and I have gone back a long way. And so as I was sharing with him, I did this recent presentation at Ventura County Mental Health Department, and I have this preparation that Benjamin's helped me with. And so we have kind of a presentation to give you today that's try to make it less academic and more personalized and more professional in terms of your application. So the whole idea for me here is that I want you to learn what you need to learn in order to be effective with people who are disabled. And so I'm open to questions. I'm open to your concerns. I'm open to your thoughts. In fact, I'll ask you to participate a few times. So those of you that are not on the screen, I appreciate that, but I would actually like you to be involved at some point and in part of the conversation, because I do think it's important that you ask the questions that perhaps you don't really have the opportunity to ask people who are disabled, as I am. You may, one of the things to be appreciative of, Dr. Cardenas and Benjamin and others of you know me, but I am actually a disabled adult. I grew up with polio, and so I am in a wheelchair currently. You can't even see it. I use braces and I use a crutches to get along, and I've survived. And so even most recently, one of my challenges is that I recently broke my leg in November. And even in spite of all my disabilities and injuries, I had never broken a bone in my body. So it took me about 2 or 3 months to recover. And currently I'm learning to walk for the 5th time in my life. And so it's been a challenge, but at the same time, here we are. And so for me, the idea is to appreciate, as I've used my experience and over the years and studied as well with people with disabilities and working with people with disabilities, that I think there is stuff to learn, not only about working with people who are disabled, but what disability really represents and means in our world and society. So I created this presentation that I'll see if I can hopefully pull up here and share with you. and move on from there. So can you see the presentation? Yes, no? Okay, all right, so we're okay there. And then I want to make sure I put the slides up. Okay. All right, so persons with disability, and primarily my focus to you today is 3 levels: awareness, disability awareness training, accessibility and issues of diversity, testing and assessment. And so it's interesting to think about the idea of how do we understand and evaluate. You are not medical doctors. I'm not a medical doctor. And so to some extent, when we think about disabilities, it is important to understand the medical side of whatever disability we're working from. And so the more we can educate ourselves and understand the injury disability that we're helping people with, the more effective we can be. At the same time, we aren't expected to know everything about every disability. So we do want to rely on the professionals, the medical field, and those people that are working hand in hand with injuries and injured people who are kind of unable. The intervention process has a lot to do with what do we do and how do we do it and what can we be involved with. Obviously, depending on the type of disability, the type of injury, the type of loss, these dynamics are going to vary with the condition of the individual. But the first place I want you to think for yourself is the concept of ableism. Ableism is really one of those areas that most of you may or may not have ever thought about, maybe till I bring up the word, because it is I would say, a privilege that we experience in our world, generally, most of us at least, who have not had disabilities, who have not been injured, who kind of suffer good health. And I'm assuming that most of you who are young and energetic and, all kind of looking at your future are many of those people. And so you aren't really as concerned with, what's happening inside your body. You're not necessarily thinking about physical injury or damage. You're healthy and alive and moving and able to operate mobily in the world that you live in. But ableism is that discrimination where people like myself and other people are not able to function appropriately or function in the way that they need to survive at times in many ways. If you think of the word accessibility, this is a very important word. How accessible are the opportunities for people with limitations or disabilities? One of the things that I always have to think about is where can I go? How can I get into the office? Is there accessibility for my wheelchair? Am I going to be able to have to climb stairs? All these conditions that limit access and mobility to my entry into society is something to kind of think about. I also want you to think about the concept, because I teach abnormal psychology. And so when we think about the idea of distress and dysfunction, the 4 Ds inside abnormal psychology is distress, dysfunction, deviance, and dangerousness. Well, distress and dysfunction are primarily the focus I'll take, but in many ways, areas of deviance have been represented. Think about the idea of the last time you saw someone who is disabled and your attitude or feelings or others perhaps towards that person. And so it is an area to think about the concept of ableism in regards to the concept of our larger society, attitudes, beliefs, and perceptions about people with abilities and or people with disabilities, if you will. I have told you recently been in a wheelchair more lately, and it's not uncommon that if I'm with my wife or with adults who are standing around and talking to me, then generally in the wheelchair, I don't necessarily get recognized because I'm lower to the person. The idea of infantilization comes to mind. And so it's important to kind of think about the idea of what are my attitudes, what are my beliefs and perceptions of people with disabilities and the type of disabilities. I'm going to bring that up in a minute for you to think about it yourself as well. The challenge then is really kind of three-pronged perspectives: interpersonal, institutional, and the internalization of this. And so from an interpersonal perspective, the relational kind of dimensions of how this affects how we feel about ourselves as disabled people, but also the perceptions of people around us in regards to perceptions of things like threats, stereotypes, bullying, all these kind of inferences that occur in regards to the concept of stigma and prejudice towards people who are disabled. I myself, I have a disability sign, but I don't put a disability license tag on my car because I'm familiar with people who identify you in different ways and throw that stigma on you. So interpersonally, it's one of those areas. How open am I? How clear am I with my own disability? As a polio person, survivor, I was educated, socialized to hide my disability, pretend I wasn't disabled, so to speak. That way people will feel less frightened of me. You probably don't know very much about polio, but polio was the first pandemic. Okay, so this is my second rodeo, so to speak, my second pandemic I've gone through. I never thought I'd have to deal with this again. But the fact is, people like myself were feared. I was isolated for a whole year because people thought I would give polio to other people. It's interesting to think about then the kind of relational kind of inventions that come about because of those attitudes. Institutionally, not only are we talking about access, but discrimination and prejudice towards individuals, if you will. I was grown as a mainstream individual. I was kind of mainstreamed into schools. Others were not. Others have been institutionalized, locked away, isolated, put in separate schools, fences between schools so that they are kind of treated differently or uniquely. Some of it is because they have to have accommodations, but others of it is that the universities or the schools don't want to pay for those accommodations because they're too expensive. Internalized then prejudice, internalized discrimination, stereotypes, a sense of inability, weakness, not being able to function is part of what the battle is at times for people who are disabled. One of the points I want to make out to you is about this idea of ableism, if you will. If you think about the concept of being aware of some of those conditions that we kind of represent in ourselves. And so I don't know how many of you have worked with people who are disabled. I don't know if people, some of you may be disabled. Some of you may have family members that are disabled. So I'm just kind of interested. I'm going to open it up for a minute, I guess, before I go back to this example. What comes to mind for you guys when you think about disabilities and the people that you're kind of experiencing, working with? What thoughts about disability and ability come to mind? I just want to throw out a conversation for a minute before I get back into the conversation.
Well, I guess my first thing that comes to mind is my family member. One of my aunts has a disability. I don't even know what disability she has because it's something that we never talked about as a family.
Wow.
So it's really interesting because all we know is that like we have to be careful around her and make sure that because she has like a mind of a child.
Yes.
So like I said, I really don't know exactly what disability that she has. I would assume kind of maybe some Down syndrome or some kind of birth.
Yeah, I mean, the term mental retardation is still appropriate in many ways when we think about severity of mental abilities, but it depends on the level.
Yeah, but it's just really interesting because like I took a class on diversity and some of my classmates, their experience was completely different. Like they were educated on what disability their family member had. They volunteered for maybe organizations that helped people with disabilities. So it was a completely different experience growing up.
Yeah, especially within our community, the vergüenza, the shame, some of the stigma, the unknown. It's better not to talk about it, let's pray for them. All these kind of aspects of kind of acceptance and understanding, but oftentimes not necessarily knowledge towards the disability itself because of the fear or the lack of education or the inability to find information, right? People just aren't given that information. They assume they know or they understand it, but really oftentimes we're not even told what's wrong. Quite often we try to protect our loved one, right? Whether it's hiding them in the back of the house or whether it's leaving, protecting them from other people, keeping them from getting, hurt. All these kind of things are well-meaning, but they often create a tremendous amount of dependency and inability, if you will, for people who are disabled. And the difficulty is that the more severe the disability, the greater the pressure on the family. You and I know that our goal is no matter what, we keep our family member at home, we take care of them. Think of the elderly person, for example, particularly grandma who has maybe dementia or starts losing her memory. We try to keep and take care of her. We don't want to put her in a home. And yet, how long can we be a hospital? How long are we a 24-hour care facility? It does wear on the family who makes those efforts sometimes. And so the more severe the family member, the more difficult it becomes. Other thoughts? Yes, Guadalupe.
Yeah, I actually had a couple of thoughts. So I was thinking when I first heard the term ableism, I was thinking about like a therapeutic setting and how accessible we make the therapeutic environment for
Yes.
people with disabilities. I also think the biggest problem in society is a taboo surrounding disabilities. The fact that it's this like really hush hush subject, like don't point it out, don't say anything. It's rude to tell someone or ask if they need accommodations. So I'm just thinking about how that could affect a therapeutic relationship and rapport building, as well as just how you set up your environment in your office, because
Yeah.
if not welcoming, then this person might not even want to see you.
Mhm.
Also, how much education you come up with, like how much you actually do the research after kind of know. I also think disabilities become a part of this individual's identity.
Mhm.
So ignoring or not paying attention to this because it's such a taboo subject is essentially ignoring some like a really big aspect of this person's life.
Yeah.
Um, so it's a struggle. And it also made me think of family members. I do have a few clients that have family members that are disabled. And just, in our culture, it's very common for the families to, we're collectivistic, la familia primero. So it makes me think of the pressure there is not only to now take care of parents, but it's also take care of siblings, or it just really made me think of how that impacts the family dynamic. Sorry for the
Well,
rant. Had a
well,
lot
no,
of
no, I think, you're absolutely correct. And I think the most important thing about your own office and your own facility is how do people find and how do they get in and how do you treat them? Even the idea, we talk about translation, for example, when you're translating with someone, the natural instinct is to talk to the translator rather than talk to the client. And so obviously then we're not communicating directly to the client. And it's the same thing with the disability, at times, with our natural indicators to kind of to address the disability, if you will, thinking, that we won't kind of offend people. And yet the reality is, the disability is who I am and part of my life. Now, I do say, and this is one of those areas that I want you to kind of hear me clearly, because the whole idea of being disabled is difficult for people who are disabled, right? Because the issue of independence and dependence comes to mind. We want to do things ourselves. We want to take care of ourselves. So when people ask me if I need help, I will say yes or no. And I would prefer that people ask me if I need help rather than just help me as if I can't take care of myself. At the same time, there are people well-meaning who say, well, Dr. Martinez, like, right, I didn't even notice you were disabled, trying to be nice to me. And to me, that denies most of who I am, because I live my life as a disabled person 24 hours a day. And so to not acknowledge my experience as a disabled person is something that's very challenging for me. So I would rather you kind of recognize my disability, not to see me as disabled, but to recognize my disability as part of who I am. It doesn't govern who I am. It doesn't define who I am. Mi familia was my protector and my support group. Because of the stigma of polio, there were many issues where I was kind of treated difficultly, harassed by other people. And my family was always my security and my safety. And so they taught me to be quote unquote normal at the family. I was expected to do everything that a family member was in spite of my disability. And that was my family's attitude towards me. You're disabled, but that doesn't mean you can't live. And that became part of the disability aspect of my understanding as my limitations. At the same time, it's not uncommon. My children grew up with this idea of people looking at me, pointing at me, trying to get close to me or asking questions about me and kind of sometimes being rude. And my children would get upset and go, what are you looking at? What are you staring at? And I'd explain to them, they just don't understand. They're trying to learn. When children come up to me to try to touch my crutch or my brace, and the madre is saying, no, Ben, don't touch it. Don't get near him. Trying to be nice. But now she's just taught that child to be afraid of me and my disability, you see? And so it's really important that we kind of turn our eye away from trying to not recognize and trying to be respectful, but always recognize that this is a part of who we are, a part of what affects the family, and the family has to deal with it every day, especially if they have a disabled child, right? Because now they have to live their life around that disability at times, as my family did for me. And so it's an area to consider in the context of recognizing the need for support and kind of care, but also recognize that the pressure is on all of the family members at some point, including my brothers and sisters who had to live with me in that way. Alexandra?
Thank you for sharing all of that. I just wanted to ask about, I've worked with cognitive disabilities for some time. And one of the biggest challenges I find is like speech or communication barriers where my client has a very hard time expressing how they're feeling, and it's just really hard. But I do appreciate that you mentioned always asking the client if they need help, because even with those communication barriers, they can usually say yes or no.
Yes.
And even just offering them to try, or speaking to them and the translator, like looking back and forth, just makes them feel so much more included. And I typically describe it as like respected, or it gives them the dignity, and it makes them feel like they're like really a part of this whole process. But the communication barrier is just something that I find really challenging. And I'm wondering if you have any pieces of advice, or if we might go into that a little further.
Well, I wouldn't disagree with you. I mean, I do think, especially if the person that cannot communicate or speak a language or others, you know, but the idea of verbal, nonverbal communication is important, you know, in encouraging that person, if they can communicate in any way possible, to communicate and not to, you know, just shut down, if you will. At the same time, we need to assume, or not assume, that people who are not communicating are not intelligent, or don't have cognitive ability, or not aware of their opportunities, if you will. One of the kind of most powerful stories I'll share with you, just since you brought it up, because I always kind of introduce this. I did have a friend who had a young man, a child who had cerebral palsy. And all of it was very severe. You know, if you know anything about cerebral palsy, your muscles are all distorted. You can't kind of talk, you can't communicate. And all he could do was kind of grunt a little bit, and he could move his eyes, he could blink. And that was his communication to his family most of his early life. His mom raised him as much as she could. She wouldn't give him up to a hospital or care center, and took care of him up till about 13 or 14 years of age. But she finally realized he was getting too big for her to pick up and bathe and put into a bathtub, and she couldn't take care of his daily needs as she wanted to. So the regional center people got together with her and said, look, the reality is he's not going to get much better than he is because of his disability, and the quality of his life and care are going to be affected as he gets older. So let's think about putting him in an institution, which they did, one of the developmental centers in the state still around. And she put him in there, and it was very difficult, and I helped support her through it. 6 months later, she was allowed to come and see him because they wanted him to get adjusted. And at that point, she walked in and saw him in his wheelchair, sitting like he always did, and, you know, kind of happy to see her. But she noticed a tablet, a board on his wheelchair. And then she noticed a pointer on his head that kind of stuck out like a stick. And as she walked up to say to him, hi, Miha, I'm here. He pointed out on the sign in the alphabet and said, I love you. She didn't know he had that capability. She didn't know he had that opportunity, the ability to communicate, because she had never been able to teach him. She didn't know the way to do this. But in 6 months, they had taught him to use the alphabet to communicate his language. Very powerful, very powerful. He only lived till about 35, because many people with disabilities don't live a complete life. But I actually met the nurse who was with him, and she really talked about him. So it was kind of interesting, the whole full cycle that I was able to learn from, because it was very difficult for that family to give up that child. I was hospitalized 5 years of most of my life for medical reasons in many different ways because of my surgeries and polio. So it was not easy to be away from home and to separate from my family. But at the same time, if I hadn't done that, I wouldn't be alive today. And so it's an area that's difficult and challenging when we think about utilizing these systems of care and helping our families to trust what's being done to their children and such, and have faith in the systems. But it's also important that we ask questions and explore, and don't discourage people from wanting to know what's going on, and encouraging them to learn about their disability and their child and themselves. I myself did a lot more education growing up, Recently, I had another surgery about 3 years ago on my spinal cord. And my spine surgeon kept asking me questions about polio. And I finally got tired of the questions he was asking because they were coming out of ignorance. And I said to him, have you ever worked with someone with polio? He said, no. I said, do you know anything about polio? He says, well, a little bit. I said, maybe you need to go study some more before you start asking me questions about my polio. So that night he went and read 10 journals of polio. And he came back the next day and apologized to me. He said, you were right. I hadn't really done my homework. I said, now we can talk about my polio, you know? Well, people generally don't have that courage to confront their medical care providers, but we can help our families be strong enough to kind of support them and ask those questions if they need to know. My mother was my strongest supporter throughout my life, and it really made a difference in my medical care. And it hadn't been for her as an advocate, I wouldn't be where I was today. So we really want to encourage families to, be their advocate for their children, not be afraid to ask questions about what's going on. Okay, let me go back to the presentation because I wanted to make sure I cover some of this other information, and we got Ben to come to talk to too. So I'm getting excited about that. Okay, so when we think about the idea of awareness, as we talked about them, institutionalized, we've kind of defined disability, interpersonal and institutional. So these are the laws that you should be aware of if you aren't already. Social Security Administration, especially as it relates to people with disabilities, especially emotional, mental disabilities and capabilities. And so they're able to kind of qualify for certain care services. The Americans with Disability Act is all about equal opportunity and access and so on. And so this is kind of the battleground. And I don't know, you're probably not familiar with it, but there's an old film that shows these handicapped people like myself in a wheelchair fighting to get to Congress. Now, I've gone to Congress and lobbied and gone a number of times to Washington for different events. But, when I've gone, there's been access so I can get in, but I've taken that for granted. But when these guys went and fought for this thing, they literally had to climb up the 100 stairs of the Congress. They got out of their wheelchairs and they climbed and crawled up the stairs of Congress because there was no access to Congress at that point. That was in the 60s and 70s. Now you can get into any place in Washington, which is pretty cool because I've been there before. Disabilities with Education Improvement Act, that's the whole IEP stuff. I hope you're all familiar. I'm assuming you are because you're in schools. This is where hopefully, that schools and the government don't want to pay for these services for our families. The less our families ask for this help, the better for the schools because they don't have to pay for it. So our job is to advocate, push, get the lawyers, whatever we can do to fight for people with disability and their rights, because everyone has equal opportunity in education. That doesn't mean they have to be locked away in a special school. My own mother, when I was in kindergarten, basically was one of those first advocates. She knew I was in a wheelchair and just literally drove me to the kindergarten class and dropped me off. And the school said, you can't drop him off, he's disabled. She says, nothing wrong with his mind. I'm leaving him here. And she left me. And that was how I was mainstreamed in public schools, in that day. So there were no laws at that point, but she was I think she was just tired of me at home, okay? And so when you start looking at the idea of disabilities, then we have these issues to kind of be aware of that we can protect and use. Now, the models we use is really three models. One is the functional model. And this is kind of the model I kind of move from, which is the idea of functional disabilities. So my disability is an inconvenience. It gets in my way, it limits what I can do in terms of functioning, but I've learned to function around it, so to speak, including mobility, wheelchairs, and these kind of things. So it is an area to think about, even in the context of encouraging people to look for support resources that will allow greater mobility and functioning. Because of my disability, I was going to physical therapy, and there's nothing more sad in your physical therapy to watch all these old people who have the opportunity to get stronger in physical therapy, but really don't want to do a lot of work. I'm tired. Let me go home. I don't want to do this stuff. When it really is about health and wellness, right? And so the health and wellness model today is really what's pushing us to recognize that there are things we can do even as we age with disabilities that don't have to limit us. And yet our attitude sometimes is, at 55, I'm tired and old and I can't do anymore. And so this is an area to consider even in the context of aging processes. As we think about children, the functional model is very emotional and difficult. I had a group where I was working with Easter Seals children with special needs in a group, primarily with autism or Down syndrome. And these were 4 or 5-year-old children in a group, and the parents were there together. And it was really hard for me because, I mean, how do you offer hope to families who really see a child as limited and disabled, and I was trying to say to them, the whole idea that my family had to struggle with the same thing. What's he going to do? How's he going to make a living? How's he going to survive? And the families that we were talking with, we all just started crying together because they're dealing with a lot of loss of their children. Their children will not have families, their children will not have children, they won't get married. And so there is a loss that goes on with many of these issues of functionality with children that we have to acknowledge. It's difficult. But the whole idea of what do children provide? What can they give us? What is the love? What is the joy we can appreciate while they're here? And this is an area to kind of appreciate when we think about what God has given us as opposed to what God has taken away. But it's an area that's not easy for people with disabilities to understand and accept or acknowledge, I always kind of think God doesn't give children with disabilities to people who aren't able to take care of them. There's a reason for that. But at the same time, it doesn't address why that person is disabled and why they're my child now. The forensic model, on the other hand, has a lot to do with the medical aspects of treatment and care and the legal aspects of practice, if you will. And so this is an area to kind of think about the law and how the law kind of creates access or inability. I was a March of Dimes child, so much of my care was provided by the March of Dimes. And because we were poor, my family were farm workers, they didn't have a lot of opportunity for medical care. So I was provided a lot of those kind of conditions. But it was based upon the idea that there was a lot of support for polio during that time. If you think about many disabilities, they aren't as supported. The politics of it are such that there still is a battle going on. As we think about integration then of functional and health issues, the disability framework and medical care, this is where I want you to kind of think about your system of care: prevention, treatment, and recovery. Preventing these diseases is critical. That's where immunizations come in. Taking a vaccination. I was born in 1949. The polio vaccination was released in 1952. By 1954, there was no polio in our country, at least not representative. Before that, thousands of people were dying on a yearly basis, just like in the pandemic today. And so it's amazing the battle I see going on with immunizations today, because to some extent there was much of that going on then, but people were more willing and accepting and trusting of the vaccination at that time to accept that model of health care. So it's an interesting thought. And, I struggle with this even with our families because there is no access to health care. It's a very expensive system of care. We'd rather wait till there's an emergency to go get medical care. And all those issues kind of create then the idea of health and disability and wellness. And so this is a model that we kind of need to realize that as we think about our bodies, and we think about our health conditions, and we think about the environment and the personal conditions that are factors, they all go hand in hand. And so I think of it as a system of care affecting our system of illness, if you will. And so illness and wellness go hand in hand. So prevention, let's prevent getting sick. Treatment, let's treat the illness as early as we can. And so early intervention, early assessment. This is where I think we really need to be more aware of our children's needs in terms of learning disabilities, limitations, cognitive disabilities as well. Our children go unassessed, unevaluated, and only until finally when they get to you guys at 3rd grade, 5th grade, maybe we see them and go, oh, there's some problems here. Why did it take so long for us to recognize those problems? I did a study on Head Start children and 1,000 Latinx children in the Valley. We studied and we did a survey at the beginning and at the end of the first year. We found out of those 1,000 children, 280 of them were having issues in school. Much of them were related to home life, healthcare, child abuse, drug abuse, things like that. We forced the families to come to therapy, to come to sessions. Once we did that, most of these families, the children stabilized. They were fine by the end of the year. And so for me, the whole idea of early assessment, early intervention, get to the families as early as we can to impact them is what we're talking about. I also work with prisons and youth and juveniles for many years. I was part of the California Youth Authority Citizen Review Board. I'm recommending we dismantle the juvenile justice system in California because it's really institutionalizing our Latinx children, and they aren't getting training, teaching, and they aren't getting medication, or they're locked in prison. So we're really kind of continuing the generation of learning disabilities in our children in prison who don't go to school. And so this is an area that we really think happening politically, how to access learning issues related to our children who are not getting recognized for those disabilities. The models that we follow then are the moral model, the biomedical model, and then the social model. And so with Latinx children and families, we oftentimes do relate to that moral model. You know, what happened to us? What did we do wrong? You know, why is God punishing us? You know, all those kind of dilemmas of trying to answer why people are disabled and why this happens to us, not everybody else. The biomedical model, you know, obviously we have a medical reason, medical condition. We can talk about what happened, but illness, wellness, disability, injury, viruses, whatever it is. And that kind of becomes the identification of the actual medical problem that we can kind of rely on. The more knowledge we have of the disability or injury, the more we can relate to, you know, what we do with it. And this becomes part of recognizing that oftentimes people don't have the correct information to make the correct decisions about what they have to do. And finally, the social model, how it impedes and affects us relational, from our families to our community, to our workplace, to just access in terms of opportunities. So it is an area to kind of think about in many ways in those conditions. As I was sharing with you about my own family, I was trained during my college years by a curandero. I was interested in curanderismo during that time of healing. And so in a training session, he offered to heal me and heal my polio. Which I thought was interesting, right? Because I was using the biomedical model that my polio was permanent and never going to go away, but he was sure that he could cure me. And I was curious about how curanderos work. I'd never actually had a curandero do anything to me, and I was curious about the treatment. And so I actually went and had him, you know, do a healing, a cleanse, a limpia. And it was amazing what he did. I mean, and I've learned a lot about that in my studies and kind of know what that's about. And for those who are believers, it can be effective, if you will. The same time, you know, the poor guy was cleaning me for a couple hours and just said, I can't cure your polio. And, you know, deep inside I'm going, yeah, okay, I understand, but thank you, you know. He says, no, you don't understand. I can't cure your polio because there's such a bad hex on your family. I go, what? He says, yeah, there was your grandfather had a lot of women and the women gave a hex on them and they cursed the oldest sons and blah, blah, blah. And I go, oh my gosh, you know, wow, okay. He says, it's so strong, I can't cure you. So I thanked him, I moved on. And I was living at not home. So I went home for the weekend and talked to my mom and dad. And so I told my mom and dad, I said, you know what, guess what I did this weekend? And I said, I went to the curandero. And they looked at me and they turned stone white. But you went to a curandero, you didn't drink anything, did you? You know, that kind of thing. I said, no, but he healed me, he did a limpia. He said he was trying to get rid of my polio. He says, but he couldn't do it. And they kind of, you know, yeah, I said, but he told me an interesting story. And so I told them the story about the hex and all that. And they again turned stone white. And I said, what happened? He says, well, we took you to a curandero when you were about 3 years of age. And he gave us the same story. I go, wow. So either it's a very powerful hex or they all went to the same curandero school, I figure, you know, and they got the same story. So I'm not sure yet, but it's kind of fascinating because obviously when we think about belief systems and we think of power of healing, you know, it's interesting the things that we will kind of look to for that in terms of hope and prayer and such like that. And yet the reality is, you know, understanding the reality of our injury, disability, our illness is going to at least help us make those decisions, whether we're including faith and prayer or not. So I'm not disavowing that at all. Beliefs are very important, but it is important for us to kind of acknowledge the facts of our disability, okay? Okay, so, and you know, one of the things that I talk about here is this idea of each client and how they approach this perception. And so I have clients who are very ashamed and afraid of their disability to the point where they hide away in their homes, even as adults, they will never go out. I've been with children who are raised in disability schools. And then when they get to the real world, they're afraid to kind of function. At the same time, I have worked with individuals who are now injured from a disability. And the injury is kind of interesting because injury during your life, it becomes real in the sense that, you know, you were healthy and now suddenly you're not, you're ill. And so the loss involved is kind of interesting to think about. For me, having a chronic illness, a lifelong illness, There are things that I've never experienced, like running, that I don't really miss because I've never done it, you see? And so it's interesting to think about those dimensions of loss. And so for someone who is healthy and then suffers an injury, that's oftentimes even more difficult than someone like me who has to learn to live with a disability most of their life, who kind of learn to accommodate, right? When we think about then different illnesses and shame and stigma, I have listed here schizophrenia, autism, Parkinson's. Much of these are kind of genetically based. And so the shame and fear is being passed on to family members, to the next generation, to the next generation. And so some of these are real in a sense that there are high risk involved. There are genetic conditions that predispose individuals. If you have two schizophrenic parents, you're going to 50% likely more have a schizophrenic child. And so those are determinants that we know of. If you're older and you have children, you're likely to be at risk to have autistic children after 45, after having children. So these are risks that we're familiar with. Parkinson's is a genetic condition. So it kind of reflects on the deficiency of our genes, our families. And so some of that is kind of that fear. It also can skip a generation or two. So we may not even be aware that it's in our family until it suddenly becomes present, okay? On the other side, I have here ghost sickness and coro. But if you think about susto, and mal de ojo, those are areas that we might define as illnesses, especially with ourselves. And so there are varying ways of kind of applying these aspects of wellness and illness to even our own cultural nuances of how we get sick and what it does to us and what it means about us, if you will. And so it's interesting to think about this, the stigma and shame of varying different disabilities as it reflects on our condition. Okay, just briefly, you can see this is kind of an age range of kind of factors associated to differing groups. And so when you think about the elderly, dementia, Alzheimer's, Parkinson's, this is the aging process. When you think about the kind of younger person, 18 to 24, that's the schizophrenic disease, and we start seeing that represented in that age group. And so it is an interesting thought to think about aging over time with disabilities, and then kind of thinking about the kind of aspect of mobility, cognition, independent living, hearing. And so the varying aspects of disability have kind of been kind of diverse in recognizing how each of these limitations may have strength or weaknesses, if you will. 2 in 5 of the elderly are going to have more disabilities. In fact, this is growing more and more. Alzheimer's, for example, is going to be kind of one of the leading #1 causes of death in the next generation, because there's so many older people who are aging, processing. If you think about women with disabilities, also, if you think about minorities in that context, 2 in 5, having these kind of disabilities. So the idea is that we're going to see this represented in all of our families, and yet the limitations, as you can see on the other side, of healthcare, unmet needs, the whole idea of not enough preventative medical treatment care, early intervention. So that's the risk factors that we kind of have to recognize. And this is why we want to encourage families to make sure that their children are getting evaluated, getting medical care, going to a doctor once in a while, getting immunizations, whatever it is they need to prevent these illnesses. So these are the varying disabilities that kind of come to mind in regards to varying dimensions. So kind of think about yourself and the ones you're familiar with. Think of the ones that you are not familiar with. Think of those that you might be working with, exposed to, and then also individuals within your own maybe home or family and some of the dimensions here. One of the questions that I oftentimes raise, and I'm going to kind of bring this up at this point, when we think about this, is this whole idea of disability as something that we will live with or survive with. And so I often ask this question. I have 2 questions I often ask in regards to talking about disability. And the first one is, and I'm not trying to harm or offend anybody, especially if you know someone or have a disability, try to minimize it, but it's kind of an interesting concept to think about it. I've struggled with it most of my life. If God were to say to you, I am going to allow you to continue to live, but you are going to have to lose one part of your functionality in terms of your body. One part of your body will no longer work, but I'm going to allow you to continue to work, to live. Now you have to pick which part of your body will no longer function. I want everybody to pick something. Okay. All right. Now I'm going to ask you to tell me what you picked. And tell me the reason why you picked that particular part of your body. Who wants to start? Thank you, Alabama.
The first thing that came to mind was maybe like a finger. I don't know if I could pick a finger, but I feel like that would be the least imposing on my life.
Pick a finger.
Hmm.
Which finger?
This one, my index
Okay.
finger.
Okay, that's your pointer, right?
Yes.
Okay, now why do you think you wouldn't have to use that one?
Because I would have another one, and also I would have 3 more to pick.
Okay. Okay. Well, that is interesting. And so I don't know how many of you thought of that, and I always do this because I have these 2 fingers that are just not working. So I mean, I don't need them either, but at the same time, I mean, each finger does come in handy, right? And each finger has a purpose and a kind of reason, like picking things up. If you think about that, finger is very important to picking things up, especially. And yet, yeah, we have another one, and so having 2 does make it a little bit easier. And so I didn't ask which arm, would it be left or right, but that's kind of something to think about as well, right? Okay, somebody else, so give me another one. I'm going to kind of keep going with this for a minute. Yes, Palube.
I chose hearing.
Okay, why?
I know that's weird since I'm in a career that literally requires me to hear people, listen to them. Because I love sunsets and I can't think about going my life without seeing another sunset. And sound is vibrations, so you could still communicate through sign language and you can still hear things if you just close your eyes and focus.
Good for you. Okay, yeah, I mean, it is interesting when you think about that. Again, I'm the poster child for all these because I'm an old guy going deaf. So, so one of those hearing things that does get a problem. I have to ask people to repeat what they say all the time, and people say, get a hearing aid, what kind of thing. But at the same time, if you think about it, it is interesting. We think about our senses, right? And the sensory aspects of our body that we rely on. I had a student about 4 or 5 years ago, and I'll share with you my own prejudice. At Pepperdine, we're on mountains, we're on hills. And so I, 6 years ago, saw a young man coming to our campus who was literally blind. And I thought, this kid's not going to make it. He's going to fall off the cliff. He's going to die, walking up these stairs in the hills. And this kid was a genius. He could not only hear things. He used sonar, echolalia, kind of thing. But he could kind of tell where you were and what was going on more better than I. He did mountain bike racing as a blind man. Think about that. So he followed the guy in front of him as the guy blew a whistle in the bike. I just couldn't believe he was doing that. But it's amazing when you think about the ideas and limitations. Charles, I saw your hand up.
Yeah, it's interesting, right? I myself have CP.
Okay.
And so when I approach this question, I would think I would want something that doesn't further limit something that's already limited within my range of motion.
Yeah.
So I'd probably choose an arm,
Okay.
my last one.
Okay. And that's a tough choice. I mean, because you're already struggling like I am. And so, yeah, what do I choose? I don't want any more, kind of.
Yeah. So it's just more like what will be the least impeding thing, right?
Exactly. Yeah. So functionality is critical here, right? And we think about that. And so, and it is interesting, I guess I am looking for a couple more shallow hells. Does anybody think about something that they figure it's not going to be a big deal if they lose that? I use the word shallow hell just to.
I actually had
Go ahead. It's okay.
my left arm for some reason too.
What was it?
I thought of my left arm for some reason too, because
Yeah. Are you
my
right? Are you
my
right-handed?
dominant. Yeah.
Yeah, I always it is now that brings up. Anybody left-handed? Because left-handers are really left out of our society. Left-handers don't have access. Left-handers can't cut scissors. They left-handed, there's a left-handed store that left-handers have to go to buy things, because if you're left-handed, you're not you're not in the loop. At our school, we have one left-handed desk for each class. So they fight over it, So it is interesting. But if you think about left and right or access, yeah, that's kind of interesting when we think about it. And yet, obviously, yeah, that's our arms are important to our balance, if you will. Okay, anybody else? Anybody else? All right, now, this is a tougher question. And I know and I don't mean to be silly about it, but it's kind of really serious. If God were to say to you, I'm going to take something away, and you would say, and then I don't want to live anymore. If God takes this away, then I don't want to live anymore. Now, some of you that haven't said anything, I'm going to put you on the spot.
The first thing that came to my mind, if probably if he took away one of my kids, that would be so something
Ooh,
that
that's
I would
tough. Yeah. Yeah, that's tough. Yeah. And you, I am assuming I wouldn't even think about loss like that, but I mean, the disability idea, hurting your child that way or having an injury or something happen. That's a good example. I haven't heard that really shared in my group. So thank you for sharing. But yeah, I would feel the same way. I would feel the same way. Do anything to me, but don't take my kids or hurt my kids. Yeah. I actually had a sister who had an individual child who was born with these problems. She was actually a at-risk child who was born at a pound and a half. Pound and a half. That's how she was. She could fit into your hand, you know. And the doctor said, let her pass away. She's not going to live. She's not going to have a good quality of life. And my sister thought of me and the kind of decisions that were made on me and said, you know, she's my child. I'm going to raise her like my child as long as she's alive. And she did. She was a little person, you know, no bigger than 3 foot tall. At 35 years of age, she's one of those rare, odd people that you kind of see in TV, very tiny. But she survived and lived a very quality life, joyous life for all of us. And so it was just amazing to see what she gave us as a person, you know, in spite of all her limitations. So yeah, those are real things. So I appreciate what you're saying. Okay, somebody else, one more thing, come on. Somebody work with me here. Thank you, Claudia.
Like brain functioning. I think if I had to give up brain functioning, I probably wouldn't want to live anymore. And I thought of that because, you know, my dad had COVID over the summer and he was hospitalized and it was horrible. And I remember one of the last things he said before he was intubated was, you know, if I don't have any brain functioning, you just need to, you know, just unplug me. And, you know, of course we didn't, and then he ended up living, but that was really impactful when he said that. And so I thought about that.
See, and to me, that's the absolute correct answer. There is no right or wrong here, but for me, that would be my answer as well. I worked with family members for, you know, all my professional life, 45 to 50 years, with people who have dementia, people who have Alzheimer's, people with Parkinson's, with people that have these degenerative diseases, we call them. And so the idea that once we've diagnosed you, you're not going to get any better. You know, it's going to even get worse and actually eventually may even cause death, early death. And so it's very difficult at times, but I think at that time, if you think about it, yes, our mind, our brain, and most people don't think of our brain as a muscle or a body part, you know, we kind of think of it as separate. And yet it's the most critical part of who we are. And so for me, that's an area to kind of be aware of that, you know, our mental capabilities is really very powerful, you know, and so this is probably one of those hardest reasons. And you had mentioned, you know, and I didn't mean to, you know, bring up your bad memories of your dad, but I think the idea that I'm happening with somebody who has a family member now, where it's like a do not resuscitate kind of thing, right? Because, you know, they're at that point too, and it's sad, but it's also, they don't want to live like that if that's how they had to live, you know? I'll share with you again, this is you know, because I want to make some time for Ben. In my polio survivor, as I mentioned to you, I have lived with polio for all of my 72 years, at least 71 years of my age. But I went through the pandemic. I was hospitalized for 5 years. I saw people dying around me who were not as healthy as me, believe it or not, because they could not survive. And most of the polio was around respiratory issues, muscle illnesses. So your muscles would weaken, if you will. And I met and became friends with a man who was living in an iron lung. I don't know if you know what an iron lung is. Most of you probably do not, because thank God you don't know. But an iron lung is basically like a beer can that covers your neck here and that covers your waist there. And it goes like this. And it's a breathing machine because he did not have his muscles to allow him to breathe. And so this machine breathed for him. If he had not been in that machine, he would not be alive. I'm old enough to know that they did not have backup generators. So the whole reality is the hospital lost electricity. He was going to be the first to die because he wasn't going to breathe. The reality, though, is that, you know, for me, when I would go and see him, he couldn't move any part of his body, but he could talk and he could move his toes. And I would watch him literally paint landscapes with his toes and a brush. And that's what he did. For a hobby, for recreation, he'd sell them, make a little money, but that's what he did. And I could not paint a lick. So I was always jealous about that, thinking, wow, how does he do that? Just like the guy who plays guitar with his toes, it just amazes me. But it's like, those are the kind of people that you kind of think, wow, I can cry about myself and look what this guy can do. So it really is important for us to kind of think about these kind of stories that go hand in hand in the context of how we deal with, because there's always somebody who's going to be worse off at the same time. The idea is to recognize that, God gives us these issues, and then it's up to us to kind of figure out what we can do with them. And I think this is one of those dynamics of understanding people with disabilities, and not having to explain everything as to why it happens to us, but understand that because it does, then how do we deal with it? How to respond to it? How do we relate to it, if you will? Okay. And so for me, at least, the message I have to you today about polio is to immunize, right? Because that's also why I do this lecture nowadays, because if not, you're going to, end up with people like myself, who can barely kind of survive. And that's not what we want. And so it's an area to think about, that if we have the opportunity to prevent these diseases and intervene early, then that's what we should be doing, rather than hesitating and being afraid to confront these diseases because we don't know what they are or what they represent, if you will. Okay, I think I'm ready to turn it over to you, Ben, a little bit for a while, and just kind of have you talk. But let's see, is there any questions that you want to ask me first? Let me just try to open it up again to the group briefly, and see if there's anything that you want to ask about working with people who have disability, or anything that I've said so far. Yes, Charles.
In the spirit of not wanting to perpetuate ignorance, but also not wanting to kind of classify everyone who's on the autism spectrum as the same presentation, because we know it's very different.
Yes.
Do you have any tips from your experience about maintaining professional care, as well as maybe adapting assessment for those on the spectrum?
Well, I mean, I do think, it's an area, the spectrum, the autism spectrum has broadly opened up completely. And so there's a double-edged sword to that.
Mm-hmm.
One is that we're labeling children autistic much more readily. On the other hand, there are certain aspects of autism that reflect different characteristics of strength and skills, whether it's communication, behavior, sensate focus kind of stuff, in that kind of way. I had the opportunity to meet Temple Grandin, who is like the autistic poster child of our country today. She is a professor of veterinary medicine who is a stoned autistic woman. Always autistic all her life, growing up, having all those autistic sensations and experiences most of her early life, but she received treatment throughout her life, helping her to acknowledge, communicate, reflect, aware of her sensory system. Psychologists have helped her understand her sensory conditions that create triggers of angst in her. And much of the autistic children that I work with early in life, professionally, I thought this was going on, but I didn't have any validation. Where children get agitated, irritated, sand in your underwear, for example, sounds that affect you and hurt your ears, for example, and all these conditions of overload, sensory overload, that an autistic child is feeling but can't explain. They can't explain. And so it's important to help them to kind of interpret where these sensories are. She used that sensory overload, come up with a way to, and it's kind of gross maybe, but it's a way of kind of moving cattle into their slaughterhouse so you don't scare them. And all those sounds were scaring them. And now all these farmers love her because she created the best way to slaughter cows and make them calm. Well, her whole thing was the sensory stuff. And now she's a professor and can communicate. She didn't start talking until she was 8, Autistic children are able to talk on the computer when they can't verbalize today. So we're kind of really underestimating autism today, and really not recognizing the independent sensory aspects of skill-based knowledge around these areas, whether it's helping them to focus, helping them to calm their senses, helping them to relate more interpersonally. I still have the films of Lobos, who used to think if you hit the kid and teach them, they would learn. Well, they did. But as the kid got older, you couldn't hit him any harder. You had to hit him harder, right? So he learned to kiss them and praise them. And that's how we use positive reinforcement, floor therapy, now it's called. So we do that to all children today who are who have these disabilities. But it really has created about reinforcing and helping reconnect the patterns of the brain that are missing, even though there is certain parts of the brain that are not regulating correctly, as we've shown, the sensory system, in her case, the amygdala. So there are certain areas of the brain that are not working the way they should. But if you help someone to recognize that, they can actually contain and control it in a way that it doesn't affect them the way they used to. Not every autistic kid can do that, but many autistic kids can be conditioned to respond that way today.
I appreciate that because I am very strengths-based in my approach to therapy. So
yeah, I always tell a story about it in People magazine about a few years ago where an NFL player, African-American guy, had an autistic young child, and the woman wrote a story about doing autistic play with him. And the guy, every time he came over, she came over, he would leave the room and never work with his kid. She finally challenged him and says, why do you leave the room? Why don't you see what the kid is doing? And he basically said, I thought my kid was going to be an NFL star like me. I thought he was going to be a pro athlete like me. I thought he was going to do all these things like me. And then she finally made him sit down and say, well, this is what your kid can do. And he started watching what he did. And now he's a real advocate for autistic people. So it's just interesting how there's a lot of fear in our own families about what it means to have a child who is unable or disabled or not able to calm down or, making a scene in the family, and how do you help that person? Yeah, it's important.
thank you,
Thank you for that question. One more question before we move on.
I have a quick question.
Sure.
So bear with me. I haven't
Okay.
pieced it completely in my head.
Okay. There's no wrong answer in my talk here.
I just wanted to know how you would suggest for us to deal with or confront or help with institutional prejudice or any institutional sort of wall or barrier that might come in with our clients that do have disabilities. And so like, what could we do to advocate, or should we even advocate? I don't know. I feel obviously that we should,
Are you talking about school-based particularly?
I'm talking about anything that has to do with an institution that might, be prejudiced towards people with disabilities.
Yes, I think we should. I think we need to. When I was with Dr. Cardenas, I actually was at UC Riverside there with him when he was in school. I actually worked for some work for the UC School for the Deaf. And I was amazed. I found a kid who was Spanish speaking and they thought he was deaf, and he wasn't. He was just Spanish speaking and he couldn't hear very well, but he wasn't deaf. And so it's kind of interesting how we kind of assume things about people, right? And their limitations and their disability. I also worked in school-based mental health where a lot of teachers would say, take him out of my classroom. I don't want him in here. Or a kid that just would be passed on year after year who doesn't know how to write his name and he's in 4th grade. And when I asked, he says, well, he's a nice kid. He got along. We liked him. So we passed him up. Wait, when's he going to learn how to read and write? So yeah, those are things that we do need to stop as therapists and kind of question the institutions of care or education or whatever being provided. And this is where the IEP comes in, the assessment. We're not doctors, we're not medical people. So get them to the regional center, get them assessed as early as we can, make sure they're getting the evaluations from the professionals who can then help us, teach us, what we need to help the family understand about their child's strengths and weaknesses, right? Rather than just assume they're lost children, or that we can't help them, or there's not much we can do. And it's the idea of offering hope is something that's very important, but a hope that's realistic in a way that says, okay, these are the opportunities or options that might be available to you. That means we also have to understand what we can do, right? What are the possibilities of these children that could actually be turning them around, if you will. And therapy is one of those areas. I think it's important that we do provide that therapy, not only to the child, but also to the whole family, and help the family acknowledge the child.
I'm sorry to interrupt you, and I'm so sorry, Benjamin. I'll let you talk right now. I have another question, and it's more about the family. So how would you navigate a family that you're working with a client who has a disability, and then the family that doesn't want to participate in treatment and doesn't really want to acknowledge this? How would you navigate that?
Well, I would address the idea of our collectivist culture in the context of how each family member can offer certain support, if nothing else, to support the other caretakers in the family, right? And so this is an area to appreciate. It's a burden, in a sense, taking care of these folks. And oftentimes it's left to the responsibility of mother, maybe the oldest daughter, the one who takes care of the kids, when the families that has to go to work. And so these are areas that we need to recognize that the impact is on every part of that person's family, the children as well as the grown-ups. And that the more that we acknowledge each of these people in the family and how it impacts them and how it affects them, the more it can be. I have a film about a family who discovered their dad had Alzheimer's. The daughter went to the doctor. The doctor told her he had Alzheimer's, and she hid the diagnosis from the mother for 6 months because she didn't want to hurt the family, trying to protect the family. Well, you can't hide Alzheimer's, and so eventually the family finds out something's really happening here. And then once they acknowledge it, they can understand then how to accept and handle dad until they have to put him in a place because he can't be taken care of at home. So the whole decision-making process comes down to helping facilitate and, in a sense, allowing that family to communicate. I've had 25 family members all about grandma, mi abuelita, what are we gonna do with her? Nobody wanted to make that decision, but everybody, well, we gotta take care of her, but nobody wanted to take care of her at home. So eventually that became part of the dynamic of, giving everybody the permission to decide. It's probably better for grandma to be at home at the hospital because at least they're going to get medical care in case something happens and they can't provide it there. So I do think it's important to appreciate the limits of the family, but also recognize the strengths and to encourage them to provide that support as a way that they can enjoy the kid or the person in the disability rather than being afraid of him or her or ashamed of her or just trying to kind of protect them from kind of not talking about what's wrong with grandma, for example. I mean, that's kind of a hard thing to do.
Thank you so much.
Sure. Benjamin, you have your hand up or are you ready to speak?
Kind of both.
Okay, so let's go. Let's take it from there. Go ahead and present.
Yeah, and
introduce
we'll,
yourself.
I think it'd be nice to take maybe a few minutes break before we go into the next portion. But I want to respond to the questions from Charles and Guadalupe because I thought they were really great. First and foremost, when it comes down to different interventions or adapted interventions, those can work, of course, but those interventions can only work as much as, I guess when those interventions would work great, and they do. And we're going to go over an intervention that does help out this population. Although I would say that the sense of community, whether it be at home or with other peers, is a very healing experience with someone who has been othered by society in many ways. So when we think about, oh, well, what type of interventions can I do? Always think of, well, how can we build community within this person's life, whether it be at school or with their family, okay? Which brings me to the other set of questions. Family systems therapy is very essential, especially with working with kids with a disability, visible or hidden. I'd say while we're trying to heal the child or adolescent through therapy, we also have to keep in mind that the family also needs to do a ton of healing. And I think Dr. Martinez spoke to that pretty well. But in the healing process, we have to understand that some of these families have never talked about a disability or the term disability, right? They've never talked about a disability model or what a disability means to them or to the family. So I really want to stress the importance of psychoeducation, especially what Dr. Martinez went over earlier in the presentation, of understanding what personal model of disability does my client fall in, and also what personal model of disability do their family fall in as well. Our client may have a very social / biomedical perspective of themselves, while their family at home, especially a Latinx family, could be taking a very spiritual approach to disability, right? And when two people or two groups of people look at a disability in two different ways, of course, there could be some friction and definitely space for some misunderstanding and microaggressions within there too. And that's definitely not conductive to creating that sense of community at home, that sense of family at home. So focus on psychoeducation. If you have any questions on the models of the disability, let us know, let Dr. C know, or look back at the slides, because the first part to healing and empowerment is giving them the language to interpret what's going on in their home. So I want to put some emphasis on that. Okay, so is it, Dr. C, is it okay if we take like a 5-minute break? Because I know we've been over an hour on Zoom, or should we just go straight through it?
Just go straight, John.
Yeah. Okay.
Yeah.
All right, so I'm gonna share my screen. slides. And these are the same slides that Dr. Martinez presented earlier. So you'll just have to scroll down to the latter half. So working in the field, I think it's safe to say, based on what Dr. Martinez was speaking on earlier, that one does not have to have a disability to have an opinion on disability or to even be subscribed to a model of disability. So knowing that even that we all inherently have our own views on what it means to have a disability, that means there is room for bias, okay? So it's important to have that knowledge and that awareness of, yeah, I have my own bias that can perpetuate either stereotypes, it can perpetuate microaggressions, and even ableism within the therapy room. So I want to present to you all what we call DAT, or the Disability Affirmative Therapy model. Okay, this model essentially ensures that one, the therapy process is a collaborative one, and two, that the therapists are able to take part in building that self-awareness of the client's their model of disability and also their own. And some of you may have seen affirmative therapy in other settings. Affirmative therapy has been used as it's been rooted in liberation psychology, and it's been used with other marginalized communities as well. So I know there is a queer affirmative therapy model out there. And I know there's a Latinx one as well. And the main goal behind affirmative therapy is to empower, to liberate, and to heal. And so I want to focus on the second bullet point here, that DAT considers the multi-systemic implications of a disability. So the political nature, the legal, economic, the educational, the sexual nature of having a disability, which oftentimes in therapy aren't really touched on upon, but in this affirmative therapy, we will. So there is a handout that Dr. C had, I believe Ben or Dr. C had sent out that goes more into these factors, but let's go over these 8 factors to consider in DAT. So DAT is split up in 8 portions, and it essentially motivates the therapist to be aware of all these components when working with a client. So first, developmental history, right? So the history of disability, was it at birth? Was it after let's say TBI, a traumatic brain injury, or an accident? It's important to understand those factors and understand the perspective that the client has on their own history. Then we have models of disability. Of course, as Dr. Martinez went over that earlier, it's important to engage with them, to ask questions to see, where do they fall, right? That will include some psychoeducation to give them this language and to have them begin to develop their own model and based on their own experience. The third one, which is my favorite, the interplay of disability and other client variables. So I believe most of us here through classes or through our own work have been exposed to the idea of intersectionality, right? That intersectionality, a person has different identities, and based on those identities, they will either hold privilege in a space or not hold privilege in a space. And it's important when working with a client with a disability that that's not their only identity, right? They can, of course, have different identities based on their ethnicity, their preferred gender, their age as well. There's a generational difference to how a disability looks for a young adult versus an older adult and all that. And of course, SES has a big role in how they identify themselves and how they're able to engage with their disability through that too. So number 3, intersectionality, and really understanding them as a whole and not just as a single identity. 4, disability, culture, and community. We'll get more into detail based on the handout, but it's important to inquire and understand the culture in which they inhabit from day to day. A school, for example, is going to be very ruthless. We all work with kids. They don't hold back when it comes down to engaging with their peers. So if a person with a disability, especially if it's a visible one, being at school could be very, very difficult. And it's good to understand that culture in which they are going to school in. And of course, community, this goes whether they're religious community or they're at-home family community. Of course, what is the culture there? How do they view disabilities in general? And number 5, how disability affects social interactions. That's quite straightforward, understanding how they communicate, how they engage with others, romantically or through friendships or even through family. It's important to understand that. It's a crucial part of any humans, and it doesn't mean it's any less important for a person with a disability. 6, cumulative effects of microaggressions. You'll be surprised at the amount of people, adults and even children too, who don't know what microaggressions are. The best way to just describe a microaggression that I've been told before is, of course, it's something that impacts us, whether it be like a verbal or nonverbal behavior by someone else that is hurtful to us based on our sexual orientation, gender, ethnicity, and so on and so forth. But with microaggressions, it's important to understand that when people don't usually pay attention to it, because imagine if you hit someone with an elbow, right? So you hit them once, and that's something that someone could really take effect to. But what if you hit them with an elbow all the time? Let's say 24/7 throughout one day. You do it all over and over and over again. You're not touching the person. It's just a slight elbow tap. But most likely by the end of the day, they're going to have a bruise. They're going to have a mark, and that mark hurts. And microaggressions are no different. Microaggressions can be really severe. They can also be very light in its impact. Some could be really violent. Some could be verbal. And explaining to the client what a microaggression is could really be liberating for them. Like, I do experience microaggressions every day at school, and I didn't even notice that. So once again, since DAT's focused on liberation and empowerment, explaining microaggressions and exploring what are the microaggressions that they experience in their life is important. And then affect prescriptions and prohibitions. This could be some of the expectations that they hold or that they are held to in society, right? Some people think that like, oh, you have, let's say if you survived an accident and it's left you in a real wheelchair. So some people might say, oh, you should be happy you survived. And that's an expectation that others may have of the client. And so it's also important to understand what are the expectations that they feel they're in or they're being held to. And then lastly, exploring intimacy with them, with friendships, with partners, with their family. How does that look like, right? We've heard about love languages. Whether you agree with the concept of love languages or not, it's really important to know that we all, as humans, love to be loved in our own way, right? And we love to give love in our own way as well. And for our clients, it's also important to explore that, because even if they want to give love in a certain way or want to receive love in a certain way, there might be barriers to that based on their disability. And it's important to unpack that and talk about it, because it's not talked too much in different settings. So that is DAT. I'm gonna stop sharing my screen and open up for any questions or immediate thoughts on DAT before we go into the handout.
I really liked your example of microaggressions and then just comparing it to, like, you know, kind of bumping into people. I feel like that's a really good way to explain it to family members, clients. So just thank you for that little tip. And just going off of the last point too, just because yesterday we had like a lecture with a sex therapist and just really thinking about sexuality and disabilities. And I think normally speaking, like my own biases and assumptions, like I wouldn't have really thought about that, and kind of facilitating those conversations. Do you have any suggestions on how we should go about that?
Yeah, we're going to go into the handout in a little bit, and there are some questions that you can ask based on that. But depending, of course, that conversation will look differently if you're talking to a teen versus someone who is, let's say, in their 20s and 30s and 40s and so on. So the conversations will definitely differ in that sense. But I'd say with older adults, just plain out asking, you know, hey, do you date? Do you want to date? Usually I ask that in my intakes, like their romantic history, their intimacy history, not to be, not to get every single detail, but just to kind of see, hey, is this part of your life right now? For some people, it's not. For some people, it is. And so it can be as simple as just asking, hey, have you thought about dating? Do you want to date? Does the idea of being in a relationship sound appealing to you at the moment? So being straightforward with adults like that usually is okay. And use your discretion. If they're feeling uncomfortable, then you can kind of lay off a little bit, but then bring it back up again at a later time, maybe when there's more rapport built there.
I was going to add, many disabled people want to be quote unquote feel quote unquote normal. And when you think about normal, the concept of intimacy, emotional, personal, and sexual intimacy are very relevant to feeling like you're part of the world. And so the fear of being disabled is that people aren't going to love you. People don't want to touch you. People don't want to be intimate with you. Or how will you become intimate, physically, emotionally? What are those kind of parameters? And so I think it is a reality that people who are alive, experience. And yet, we oftentimes discourage that kind of conversation, or we're fearful, or we don't think about that in that way. But intimacy, I think, is a very important part of feeling that you're a part of this world, if you will. And so I do think that's an area to consider in terms of love, as Benjamin mentioned. I think that's very important, feeling loved and being able to share your love with others. Any other questions for Ben?
I have a question.
Yes, Gabriella.
I do work with a client right now who she has a disability on her arm. Her arm, she got into an accident when she was a teenager, and she lost complete, like she can't use it anymore. She says she doesn't even have, like, pretty much it's just dangling, and she's in a lot of pain and everything like that. When we first started therapy, we did talk a lot about this because I know it's part of her identity. My question, I guess, is throughout therapy, I don't want to just ignore that part, of her disability, because I know it affects her. She needs medication, and even like in her partner life as well. I guess, what is an appropriate way to bring it up throughout therapy? My question.
That's a great question. My follow-up would be, does she consider it as one?
Yeah, because she can't drive. She drives with one arm. She, like, even that as she works, she finally got a job, so she was really excited because she hasn't been able to get many jobs because they see her and they immediately, like, just push her away.
This is where I think right now I would encourage you to think of the words grief and loss. I'm a firm advocate of Elizabeth Kubler-Ross's Death and Dying, and the 4 stages of our acceptance, if you will, of this. And so if you think about the idea of grief and loss, grieving what she doesn't have, understanding the loss of her arm is part of the process. The unfortunate part is that it's constant. It doesn't go away, because each time she isn't able to use it, she's reminded of the loss. And then the grief comes on, okay? And so the question is, and it's for all of you, how do you grieve? How do you mourn? We all suffer losses. One of the examples, often I didn't share to you today, but it's important I share because it's kind of one of the parts I get into now, is this idea, for example, of losing something when you were functioning and then now you no longer have it. For me, I think of the veterans coming back with their legs blown off and their arms blown off and feeling now they're not men or women again. They're not whole people. When in reality, now that we know they can learn to use artificial limbs and things, they can be just as whole as anybody else. Even the Paralympics, shows they can do things. So this is kind of the concept where you think about our limitations. Do they define and own us and control us? Or can we, in a sense, confront and challenge those expectations? And so I do think it's an area to think about. And so when she does bring it up, or as she doesn't bring it up, not to just go over it, but to kind of bring it up in a way of what it reminds her of. What are those issues of loss? And how does she grieve that and move on with that, if you will? part of it is being able to function, like you said, but now I got a job, now I'm okay, now I'm kind of being accepted. And that's important for her to recognize and validate that in a way that she can feel whole again, rather than dysfunctional, and that's an area that we carry with us, that stigma, right? And people are going to see her arm and kind of still look at her because she's, what's wrong with you, kind of thing. So she will have to acknowledge that. She can't deny it, but she doesn't necessarily have to let it define her as her. I think that's the hardest part.
Yeah, I agree with Dr. Martinez. And let's also think what happens after we grieve, after we have a loss, however much time that may take. Acceptance is a big part of that healing process, right? How does acceptance look like for our clients post grieving, post understanding the impact that it's had on their life? So I'd say, yes, speaking with your supervisor, getting to really understand acceptance, and how does it look like for further healing process. And not to rush that. I think that's another important part to what Dr. Martinez was saying, is that's a process that is not rushed. This can be, the grieving process, not like a typical grieving process, because there's a constant reminder of it, in their body. So
I'll share with you, as a polio survivor, my left leg is the same way. My left leg doesn't work. It has no muscles. It is kind of a limb that hangs there, and I have a brace that helps me support myself. But when I don't have my brace, it's pretty useless. So I have had to learn to accept that part of my functionality or dysfunction as part of who I am. But again, with my appliances and ability, I can kind of confront that and challenge it. And so, I don't know if she's able to kind of even look to that to kind of find ways to help her facilitate, but it might be worth, exploring even with what she's looking for, if she even wants that, Okay, Benjamin, go ahead with a little bit more recitation, I guess. Okay.
yes, I want to wrap it up in a bit so then we can have some time to just have a general discussion. So I'll continue on with the slides. We just have a bit left. So after DET, we have some considerations as providers that that it'd be nice for us to have. Some of them you probably already do in your current practice. This is just more as a reminder. Okay. So I want to focus on this last bit here at the bottom. Recognize that most clients with a disability may view their disability as a basic and valued part of their identity. This kind of coincides more with their own model of disability and how they define and identify as themselves. But it's also really important to understand that for them, it could be an asset, right? It could be a strength, a sense of pride almost. And it's important to make room for that, because if we, let's say, don't view a disability that way, we could run the risk of imposing our view and projecting our view into their own. Most importantly, collaboration. We went through this already with DAT. It's very important to collaborate with the client on treatment plans, on intervention building, even with the psychoeducation, right? Collaborating with them on how psychoeducation looks like, how therapy is best done with them. Definitely for kiddos with a learning disability. Sometimes it involves changing how we speak, the length in how we speak. Maybe we have to speak in single sentences, slower, or maybe even faster, maybe using drawings. So that's the type of collaboration that we should always be thinking of with our client. Checking in, is this going well? Could we change this in any way, right? Are you feeling comfortable? Are you not feeling comfortable? And here I want to go over some of the important points. Listen and hear, that goes with collaboration, right? We want to listen and hear them out. With that said, we all bring our own biases to the therapy space, and that's a human thing to do. I'm not saying don't feel those biases, but it happens. But a good way to mitigate those is to listen and to hear them and to have them define their own experience. I'd say a big one is be knowledgeable. It never hurts to do extra research on a disability. and the current therapy methods used for that population. And that's what it means to be competent. Not only is the collaboration part is a big part of being a competent therapist, understanding intersectionality is part of being a competent multicultural therapist, but also making time for us to do our own research and be knowledgeable about these topics is also going to be important. And on that note, one can read research articles, can read other case studies, but a big part of being knowledgeable is also bringing in that humble mindset in the therapy room to be open to their experience. Because it was someone with, let's say, who, I'm trying to think of something, who, let's say, has a learning disability. It could look very differently for many different people, of course. So being knowledgeable is also having that open mind with our work. And advocate. This is something that we talked about earlier. I think, Charles, you asked about how to advocate within a system. I know when I was at Luminitas, I worked with principals, with teachers, with teachers' aides constantly, along with their family. And so when an advocate doesn't mean necessarily to do policy work, but really advocate for our own client in the spaces that they're in. If they are getting bullied and the school's not doing much about it, then we can be a force of change in talking to whoever's in charge at a school to hopefully make that change, or maybe have the school listen and be open-minded about our client. So that's how advocacy in our own sphere of influences and our own therapy practice looks like. This is a great graphic from the CDC that they put together, is using person first language. Who's heard of this before? Using person first language. I've heard about it, not necessarily in the disabilities realm, but here they've done a really great work on some of the stuff that we can do, that we can learn now to be a more inclusive therapist with our clients. So you can read this on your own, it's on the slides, but most importantly, an example would be, let's say, do not use language that suggests there is something lacking. So we can say person with a disability instead of calling someone disabled and handicapped. Okay. This is very important when doing family work, especially if there are differences in generations. You could see folks who are part of an older generation who uses stuff like disabled or handicapped, or uses stuff like midget, like they say here, or other words. The R word comes to mind that the old generation constantly uses. So part of the family healing process is to also, if you do have a family setting, is to introduce some of these words. Like, hey, instead of saying this, could you use this? Could you use this? Could you use this? So this could be very good for our own practice, but also for our family therapy practice too. And one of my favorites, the sunflower lanyards. Who's seen these before? They're actually quite new. I actually found it through TikTok, actually, through mental health TikTok. And I see a lot of therapists using it. And apparently it's a whole thing that I've never been exposed to before. But apparently there's this lanyard you can buy in bulk from their website here, or you can also get it from free on other websites. And essentially, it's something that our clients could wear, and it says hidden disabilities like this. And from what I understand, there are a lot of public spaces, whether it be libraries, airports, especially with TSA, and even some schools, really any government or federal government run institution are usually pretty aware of, if you see a sunflower lanyard, you're going to be more patient and be more accommodating for that person. Okay. Now, this is completely a client's choice to wear this. What I'm not saying is kind of getting one of these and kind of giving it to your client and say, hey, wear this. Like, no, because if one wears it, you are telling the world that you do have a disability, one that you can't see. And so some clients are okay with that, some are not. So use this as a tool, but always keep in mind the needs and the level of comfort that a client has with such tools. Okay. And that is it. Any questions?
Two points I would add to Ben's conversation. One, I use the word handy capable. And so you think about the idea of handicap, the idea of not being limited. And so this is the idea of changing the language up, I think is very important. And the other thing he mentioned about the idea of hidden disabilities versus, visible disabilities, it is a kind of catch-22 because some folks who have a hidden disability don't want people to know. And so there's that stigma about, once I let people know, then I'm going to be seen differently or be treated differently. And so I think it's an awareness that we just need to understand that even though we're trying to help people understand and acknowledge their disability, there are some social stigmas involved that don't necessarily just encourage that at times in our society, in our families. And so this is some of those areas of the kind of stigmas that still kind of present themselves with varying limitations as well. Okay, we're open up to questions. Who wants to ask anything? You can ask anything about me as a disabled person. I will not be offended at all. I'd rather you ask me than ask your clients. And at the same time, if there's anything that we've brought up in terms of our conversation that you want kind of clarification or share, I would appreciate that, especially your own challenges. What are your own challenges now that we brought this up to the surface? The idea of bringing this up from the unconscious to the conscious. And now that you've become more aware of it, then what do you do with this information? How do you acknowledge it? What are some of those struggles that you're still left with is my question.
I have a question, of course. First of all, I wanted to thank you guys for your presentation. It was very informative and very helpful. My only question that's kind of left over is countertransference. I think that's like the biggest thing that a lot of us would face.
Related to what when you say that? What do you kind of be specific?
I mean, as in like our scope of practice and just our trainee position and kind of how we might not feel like we have the proper skills, assets to help a person with a disability that might come in to get services.
Mhm.
So I was just thinking about like how any suggestions on dealing with countertransference. You guys touched on it a little bit, but I just wanted to get a little bit more help on how you would suggest for us to deal with that.
Well, I think it is important to appreciate your triggers. What triggers you in terms of disability? What disabilities would you feel uncomfortable with people walking in your doors? Which would be challenging most to you? Would you have the resources to provide care for that person? Would you even know where to send them, for example, as your research outward network? And I'm throwing all this out because these are your responsibilities, right? And so it is important for you to kind of acknowledge that you do your work before they come in. So, you're able to kind of present to them some alternative options or thoughts about how it relates to their own experiences, rather than trying to kind of do a one size fits all, to everyone that comes into your office, right? And so it is important to kind of think about this as a specialization where you can specialize tremendously and work with people in this regard, or you can simply be offering more of an open door to people who come in and be ready for them when they do. And the same thing, recognizing the kind of fears and apprehensions. I always think about the sympathetic and parasympathetic nervous system and the whole idea of dissociation. And so when someone walks in the door and suddenly you're kind of dissociating, you're not there, you're thinking about the next client, you're kind of getting scared about their disability, you're beginning to escape, you're getting to flee, flight or flight. I got to get out of here. That means you're not present. Not being present means you're not available. And not being present means you're perceiving a threat. That threat says something's happening here that I don't feel comfortable with, whether it's my own skills or maybe I'll catch the disability. We don't know. There's all these inferences. Our instinct is to keep away from things that might harm us. That's just our natural instinct. So anyone that looks disabled or perhaps injured, what happens if we catch it, kind of thing, like COVID's going on right now, right? Think about that fear that we carry with us. And so it is real. It isn't something we need to deny, but it's also to acknowledge it. And then in a sense, check in. Where does that come from? Why am I feeling this way? What's going on? Is it real? Is it relevant? Is it going to interfere with the work I'm trying to do here? And so I do think it's a conscious decision that we need to make, just like we would about any privilege where we're not aware of it, but then suddenly we're aware that, this is a whole different environment here. And so I do think it's acknowledging that at that moment that will help you to kind of facilitate what you need to do.
Thank you.
And to add to that, as a reminder, countertransference can be very unpredictable to the point where it won't come up until it does, right? And so with that, give yourself some grace. There's not there's nothing you can do to completely anticipate all countertransference and all the biases that you have when working with a population, because it can come up very randomly, and that's okay. I would say, relating to this population in particular, understanding your own model of disabilities is very important. That's something you can do now, and then do that personal work however long it takes now. Dr. Martinez was really smart to kind of ask those questions of what part of your body would you give up, let's say. And that is very important to ask, because it engages with our own bias and our own countertransference, one could say. So do that work. This type of reflection does not have to end here. Take it when you're meditating, when you're out and about, just something to think about. But ultimately, understanding where you fall on those disability models will help a lot for you to anticipate how you might feel when you do encounter a client who has a disability.
We're often taught to be very delicate around people who are different or disabled than us. And that's, you know, in a sense, that kind of creates a certain fear or apprehension about how to approach people. So I do think it's important for us to kind of take that risk a little bit and kind of move ahead to that, to kind of acknowledge it, just like we would with any other issue that's kind of uncomfortable to bring up, you know? Okay, other thoughts, other questions? Yes, Charles.
Perhaps this is more on the increasing scope of competence side of things, but I'm at that stage of my career where I'm in that transitionary period after graduating, getting my degree, but I'm still waiting for that associate number. So the thing that's been a challenge in terms of increasing my scope of competence, just in general, but we can apply to this population, has been being kind of blocked off from those journals that I used to have free access to because I was a paying student. Right. So I think this is a wonderful opportunity to hear maybe from both of you from your experiences, continuing to read the literature, continuing to increase that scope of competence outside of academia.
Well, even better, I would even encourage you to go to conferences and go to training conferences. You know, I met Dr. Grandin at the American Psychological Association convention that happens every year in, you know, summer, and it's a nice little trip. But these are where all these people get together and really talk and share about her experience. She talked to 1,000 people, you know, all about autism. And just, you know, just to learn from her about what she went through is just so enlightening. And you don't get that in some of these journals sometimes. So I would even encourage training and kind of going for further training around some of these areas, whether it's the psych associations or the MFT associations. There are opportunities to expand your insights. I agree. You know, journals are another thing. Unfortunately, they are limited to academia sometimes, but that could be something even that maybe our center could do more. Dr. Cardenas, Luminarius can be more, think about how to gain more access to some of that information. But you're right. I mean, that's some of the things that's currently going on. And so it's good to be on top of things that are happening now, where the research and journals is actually 5 or 10 years out of date almost. So I would say conferences or training sessions that you go to would be ones that I would encourage you to do, and not be discouraged by it, because, you know, each one's going to help you in different ways. So good point, though. I think we always need training. We always need training.
Thank you, everyone.
And
resources.
I have a comment. Dr. Martinez and I are more of the senior people here, so you have more life experience in different settings. And yes, I do remember now, because I was still waking up this morning. It was abnormal psychology class at UC Riverside. Okay. It was interesting. I want to continue, and I want to be a psychologist after all. So anyway, I'm thinking about a client that I saw a few years back. He had Asperger's disease, and he was about my age and disorder. And I really hadn't worked with an adult. You know, we talk about autism spectrum and children, right? And this is an adult who had a job, who lived with his mom, and he was in a pretty solid situation. He worked, etc. But I found that what was really an honor for me, really, is I was there, and the handout was really good in terms of all those things. Like, man, I did a pretty good job. I did that. I learned more. I was humble, you know, and all that. And then, but he was stuck. He hadn't had any sense of normalcy since elementary school, when he had a group of friends and his brother, and they would do these regular things. And after that, everybody continued on, and he was stuck. Okay. And so he had never, so it was about helping him accept and agree that he had never experienced what his friend moved on to experience, dating, never had a girlfriend, never, nothing like that. Right. And of course he still had those thoughts, like he was attracted to people and all that, but there was no one he could speak to. His brother was now out of state. He had a pretty close relationship with his brother and his mom. He lived with her, and she was an amazing older woman who was like sharp and really older, and so he didn't have any economic issues going on, but he really needed that place, and I provided that place where we could talk about anything, and he could finally grieve the loss of his friendships, the loss of the things that he didn't ever experience, and also I because I did things differently. I went to visit his mom at his house and his room, and I walked into his room, and his room was still like he was in elementary school. And this project, remember the Addams family and all that? Well,
Yeah.
Dr. Martinez does. He had some models and different things like that. It's like, this is just like this he was when he was a little kid. And this is like 40, 50 years later.
Yeah. Yeah.
Okay. And so, so being able to help the persons, have a space where they can talk about these things, right? And of course, for Asperger's person to cry, to tear up when they're like so limited, in what they evoke and what they share.
Yeah.
And that was great. So in terms of being able to say, wow, it was a real lesson for me of, I needed to learn about it, and I needed to really meet him and not back off and not assume it's like, well, what can I do with this guy? He's okay. Nothing really to work on, but he really needed to have that place where he could finally emote in his way and talk. And also he had all these words that he would just hold back, because he's just this quiet guy who just walk around and look kind of different, but he wouldn't engage anybody. But to now have a space where I was actually pushing him to engage me and to let him know that whatever he said was fine. There was so having that space where, you're not going to be critiqued or criticized. In fact, I was curious. I wanted to know.
Well, see, that's it kind of brings that to mind, and this is our families. Our families are well-meaning. They don't want to pressure people like this. They don't want to put a lot of expectations. They'll take care of them, protect them, nurture them as much as they need to. But at the same time, that creates then developmental lag of emotional, psychological immaturity in terms of who we are and kind of the individuation, right? Be all you can be the adult, grow up. Well, when you're kind of taken care of like this, there is a tendency to be codependent, to be dependent, and you are reinforced for that. We'll take care of you, mijo, And so to that extent, it can be very seductive where you kind of don't realize that you're being taken care of, but then you don't learn how to take care of yourself. So I've had to deal with this where elderly Latino families are dying away. Mom and dad is now dying away, but they've been having their son protected in the back room, taking care of them. And now what do we do? And he's 50 or 40 and he doesn't know how to take care of himself or make a meal. He could have if they had provided that socialization, but they did it for him. And so that's kind of the harder struggle of individuation and kind of being independent and kind of growing developmentally. And so it is important to recognize the developmental, emotional, cognitive ability of that individual, as well as the physical stuff. For me, my family supported, protected, buffered me from most of it developmentally. And the expectation was you're going to be a regular guy, no matter what your disability is. And that was kind of the pressure I felt. So there was different expectations on me than there was on other people that I grew up with who were, protected, isolated, hidden away, and didn't have the same kind of acknowledgement of their disability throughout their life. So it is important we don't take that for granted, just get up and do this kind of stuff. Well, if you've been raised all your life to have others take care of you, it's hard to know what to do and how to do it. So we really have to start from that base of where that person starts and move from there, right? So where can we start developmentally from where that person's willing to give us, but then encourage that growth, right? Not kind of encourage staying where you are, so to speak, developmentally, cognitively. And this is kind of part of the challenge at times if you're not used to or have never been acknowledged that way. So because you kind of grow up thinking that you're going to be taken care of, and you don't really realize it until sometimes it gets too late. So that's an area that we have to be cognizant of as well. Individuation, independence. The collective is good because it supports us, but it's also important to help that individual self-identify and realize who they are, acknowledging who they can be throughout their life, you know, not defined by simply the group or the family. Other thoughts, other questions, other reactions to the talk? Anything else you want to
I just wanted to also just say for anyone who wanted more resources or just kind of be more informed, I understand that you know, journal articles and peer reviewed and all that stuff is very beneficial in working with clients, but also just getting firsthand accounts of what it's like to be part of that community. So I really do value social media, just following people who actually live in these experiences, because at the end of the day, the clients are the experts in their own experiences. And also just kind of, I have a disability. I have ADHD and PMDD. So I think for me, what has kind of helped me, and recently diagnosed, I think what's really helped me kind of in my own journey about learning about my disability is learn about third order change. So like reading Paulo Freire, Pedagogy of the Oppressed, learning about how these systems weren't built for people like us. And so acknowledging that, listening to your body, and I know like sometimes kind of going into these topics might scare some people, but sometimes like acknowledging to people that it's like your worth is more than just the value that you produce in the society under capitalism. Like you are more than just what you give to the rest of the world. And so like the 9 to 5 sitting on a desk isn't for everybody, and that doesn't make you less than anybody else. And having these conversations with clients where it's like they tie that, where it's like, well, if I can't work, I'm not good enough. Also diving into these conversations as well.
Yeah, you know, when I talk about these things, and I haven't mentioned, but I always think of mind, body, and spirit. And it's important to integrate all those conditions, if you will. And so I think, especially you're right, I have learned to handle my pain. I've lived with pain all of my life, just as you've lived with your disability. And you learn to handle yourself in certain ways. You learn to take care of yourself. You do things to maintain yourself so that you can continue to function. And so it is an area to help educate, but also encourage individuals with a disability to self-empower themselves, to kind of educate what the disability is and is not, what are the limitations, what is it not limited, and to not kind of live by those expectations, but to kind of live beyond those, you know, in a way that we challenge those expectations. And so I do think it's important for us to also kind of think about, as you're saying, what are our expectations of that person? If we don't expect too much, we're not going to encourage too much. And so it is important, you know, not to put our agenda on that person, but to allow that person to kind of explore and encourage them to kind of look beyond their limitations and their disabilities as well, especially if that helps heal their heart. I think that's a real important part of this. So thank you, Monica. I appreciate you sharing. Okay. Any other thoughts? Any other questions come to mind that you want to ask about, or just in general, or anything that's specific related to the issue? Okay, well, at least for me, at least I have tried to provide to you a kind of foundation of working with families and disabilities. And at the same time, you know, when you think about the community, I'm a community clinical psychologist. So I think systemically, and I would encourage you to think about your own network of disability resources and access. Who do you know? Where would you send these folks? How would you address those areas? And so it is important to kind of think about this idea of, you know, a network of care. So you aren't responsible for all of it, but you are responsible to help direct. I've used the regional center a lot in my practice with people to get them to get evaluated, get them to get assessed, get services as early as you can. The earlier you can intervene with the kid, the better. If nothing's wrong with them, great, then they won't need it. But if there is, the earlier we can intervene, the better we can do that. So I do think these are areas where we think about developmental disabilities in that regard. Charles, you mentioned about infantilization. And I guess the one thing I will say, you know, if you think about the id, the ego, and the superego, you know, and so I kind of am a psychodynamic person. And so if you think about the ego is the adult we're trying to all be and grow up, but the id in us is that little kid. And so each of us, especially as disabled people growing up with disabilities, we remember those childhood memories. We remember that pain. We remember the loss and suffer as children. And at the same time, those memories are not easily forgotten. You know, the trauma associated, the transgenerational trauma associated with disability is historic. And it is important to recognize that these things are building blocks, just like the microaggressions build and leave bruises. The whole historical trauma leaves a nightmare of trauma historically. There are many things that I have purposely forgotten, I know, especially around the idea of people living and dying in the hospital around me. But the things that I kind of remember are those things that have helped me continue to survive and kind of gain my strength in those regards. So I do think it's important for us to acknowledge the challenge and the struggle lifelong of disability, and to kind of not to simplify it, but also to acknowledge the idea that of empowering oneself throughout this process is taking control of one's life, as opposed to letting the disability control ourselves or define ourselves. And so, as I said to you before, I want you to recognize my disability, but also recognize that it doesn't define who I am. Okay, and so that's an area to kind of appreciate as you're working with children, or you're working with adults, or you're working with individuals, whatever they be, if you will. All right. Thank you very much. I appreciate it.
I think we're now at 10 o'clock as well. And as we can see, you're really doing a great job, Dr. Martinez, Ben, because people haven't logged off yet. Okay. And it was a great job. Yeah, we are advocates, right? But we are also, we need to be humble and know, like, we don't know everything. We can't know everything. And as was mentioned, now we have also all these resources, TikTok, et cetera. People say, I have this, but I'm able to still do this, right?
That's right.
I didn't have a problem, and now I do, or I have a loss. And so being able, but there's all these entities out there, all these people out there that want to help us help our clients, right? And so being like regional centers one, and it doesn't matter. I had a client who was in her 50s and she'd never been evaluated officially at regional centers. She had mental retardation. Educational mental retardation.
Never too late to be evaluated.
Yeah, but you have to learn the legal part and all that to make like legally you have to show that there was something way back before 18, and we were able to. Okay, so but being able to see that you got to do a little more advocacy, I guess, than what just the client coming in. How are you doing? Boom, you leave. We need to do some things in between, and that's what we're here for as an agency, right? And when we need to sign things, your supervisors sign things, sometimes they need to have a psychologist. Well, I'll sign it. We'll write it, we'll sign it, we'll get it done.
Well, I am your consulting psychologist, all of you, and it's so happy to see all of you, your brown faces here and being trained. And so I want to encourage you as much as I can to continue everything you're doing. So you can always contact me. You can always give me a call. You can always Zoom me up, and we can always talk. Okay, so I'm available to you as you need to.
Dr. Martinez officially is a part of our board as well for Luminaria. So just so you guys know, he's not just a friend of mine and a colleague, but he's
not just a pretty face. I'm not just a pretty face.
He's such a humble guy. Anyway, thanks a lot, Dr. Martinez. Thanks a lot.
Thank you, guys.
Ben, and we'll see you all later. Okay.
All right. See you guys later. Bye.
Thank you so much.
Appreciate it.
All right. Thank you again.
Thank you. Thanks, Dr. Cardenas. See you soon.
See you soon. Take care, man. Bye.
You too.